With regards to optimization of CAR T, there's several observations that we made from the ZUMA-2 trial that I think also dovetail nicely on data with Tisagenlecleucel in the pediatric and young adult setting, also dovetail on the data from J-Park in their phase 1 study of CAR T-cell immunotherapy in adults with ALL. The first major observation is tumor burden really does matter. And particularly as we go to very, very high tumor burdens, that is 75% and above, we are seeing less CAR T-cell expansion and less overall efficacy. And so we need to figure out how best to bridge patients so that they come into CAR T-cell therapy with a lower disease burden without causing excess toxicity. When we tried to do this on the ZUMA-3 trial, one of the key observations is, look, if you take someone who's chemorefractory, again, recall the median prior lines was 3 on the study. When you take someone with multiple prior lines of therapy, chemorefractory disease, and you say, okay, I'm going to give you high-dose cytarabine or fludarabine-based therapy in anticipation of reducing that disease burden to get you a better outcome with CAR T, all you get is toxicity, right? They're already refractory, and the likelihood they're going to get a major infection that precludes CAR T-cell immunotherapy is high. The likelihood you're going to fail manufacturing is high because they're just too beat up. So we need to come up with better ways to bridge our patients to CAR T-cell immunotherapy to achieve that low disease burden, to optimize our response. Now, one of the things we didn't allow in the trial was the use of novel agents like Blina or Ino, and I think that that's something we definitely need to explore. Now, that's being done in the pediatric setting already. I think Novartis has a study that's ongoing looking at Inotuzumab bridging prior to CAR T, and really hopeful to see how those data pan out, so that we get a better sense of whether this is going to be the direction we need to move in. Still complicated, of course, by the fact that, well, what do you do if someone's already had INO and failed INO? And so, again, I don't want to imply that that's the only direction we need to move in. But there are other agents, right? We have venetoclax, which has shown I think Wendy Stock and the group at Gene for Chicago have shown that really this can be an effective tool for some patients with acute lymphoblastic leukemia in terms of disease reduction, and potentially may do so with less toxicity. Other agents, CD38 targeted agents, for example, may provide another avenue for trying to modify disease burden in that space as we go to CAR T-cell immunotherapy. So, again, I think we still have some more work to do to really get at this answer of optimizing disease burden, but we do recognize that that's an important component. Now, the alternative is to move CAR T forward, and this is something that our pediatricians have already beat us to. So the Pediatric Real World Consortium data set, this was presented by Lori Schultz at ASH, really beautifully showed that for those patients who had very, very low disease burden, meaning now CAR T, at least the way that I interpreted the data set, was being used as a consolidation. In some cases, in earlier lines of therapy. So now not waiting until someone has failed 2 lines of therapy, but being used as a consolidation earlier. Not only did it come with less toxicity, particularly for those with fewer than 5% blasts, but it also came with greater efficacy. And that efficacy was not just a response rate, but if you look at their EFS and their OS data, it really seemed to provide a more durable response. So for me, this is a highly encouraging data set that informs how we need to start thinking about CAR T-cell therapy for adults. Thinking about now, you heard me broach the transplant question, how do we circumvent or avoid the transplant if we can? Maybe the answer is thinking about CAR T-cell therapy as a consolidation in an earlier, therapy line, rather than thinking about it the way we do now, as a standalone therapy for relapse refractory disease. In other words, I guess what you hear me saying is we've taken our novel agents like Ino and Blina and moved them into frontline therapy, moved them into sort of management of persistent MRD. There's no reason why we can't do the same thing with CAR T-cell immunotherapy and try to take advantage of that low disease burden so that we optimize the benefit and minimize the toxicity.